Assalamu alaikum. This is a presentation for medical students by Dr. Mumtaz Ahmed Umar, and today's topic is posterior rhinoscopy. Learning objectives for this presentation is one should know what is posterior rhinoscopy, understand its indications and contraindications, know the instruments which are needed to perform this procedure and technique step by step, and able to visualize the structures and able to draw them even, and be aware of the precautions and complications if arise any. So for introduction, posterior rhinoscopy is an OPD based procedure and a part of routine ENT examination. It is performed with indirect visualization of the nasopharyngeal area using a posterior rhinoscopy mirror. So the name of the instrument is the posterior rhinoscopy mirror. Again, not the posterior rhinoscope, but the posterior rhinoscopy mirror or the step-up mirror. You should remember for indirect laryngoscopy, the mirror is straight mirror. So this is a step-up mirror, and obviously with a headlight to pour the light inside which reflects on the mirror, and we will be able to visualize the structures. It is again an essential ENT clinical skill like indirect laryngoscopy for all medical students, and they should know how to perform it. Definition: examination of the posterior nasal cavity, the posteriormost part of the nasal cavity, nasopharynx especially, and the related structures using a mirror which is introduced through the mouth and held behind the uvula. In indirect laryngoscopy, we have raised the uvula from the back side of the mirror, but in posterior rhinoscopy, mirror is facing upwards and it goes behind the uvula. It is usually, as already mentioned, is performed as a part of routine ENT examination, but especially in those patients who present with chronic nasal obstruction and nasal discharge, post-nasal drip, evaluation of any nasopharyngeal growth or masses. Adenoid hypertrophy is one of them. Nasal enteroquinal polyp is another mass. Angionasal pharyngeal angiofibroma, nasopharyngeal cancer. These are some masses which are present in the nasopharynx, and choanal atresia as well. But since choanal atresia is a congenital lesion, so it is not possible to visualize in very small children. We'll come to that later in contraindications and limitations. So that is one limitation for this. But choanal atresia can also be visible in uh, grown-ups, teens, or boys, small boys, or I mean above the age of 5-7 years if the child is cooperative. Contraindication or limitation if the patient is very much uncooperative, because for both these procedures, indirect laryngoscopy, posterior rhinoscopy, patient's cooperation is mandatory. In small children, it will be difficult to visualize. If the patient has a strong gag reflex, yes, we can instill local anesthesia and then can try in this patient. If a patient has trismus, because if the patient is not able to open the mouth, then it will be very difficult to introduce the mirror. Any patient with orofacial trauma or kissing tonsils, as we have to go behind the uvula. So if there is no space due to the area occupied by the tonsils, then mirror examination will not be possible. Instruments required is the head mirror or the headlight, the mirror, which is the main part, tongue depressor, either metallic or wooden, you can use any. Metallic is preferred, and a flame, a lighter, spirit lamp, which is used to heat the mirror and to prevent the fog. So this is the picture of the equipment. This is the headlight. This is the step up or the posterior rhinoscopy mirror. This is the tongue depressor, metallic one. This is the wooden tongue depressor. You don't need both. You need either of them, and a lighter to start the flame. so the mirror can be heated, and the and mirror side has to be heated, not the back side. So the procedure steps is patient sits upright with head slightly forward, mouth is open and the tongue is depressed with the tongue depressor. Again, remember that when we are depressing the tongue should stay inside the mouth. It should not come outside the mouth, because if you bring the or protrude the tongue outside and then try to depress it, it will not depress, because tongue will already be stretched, so it will be difficult to depress at that moment. So for proper depressing of the tongue, it should remain inside the mouth. Warm the mirror, the posterior rhinoscopy mirror, and this after checking first on yourself and then on the patient. If patient is satisfied with the warmth, then it is introduced carefully into the oropharynx behind the uvula facing upwards. Do avoid touching the posterior pharyngeal wall, otherwise it will induce the gag reflex, and adjust the angle and direction on both sides a little back to visualize the structures. So first we will heat the mirror, okay, and after heating we have to, if it becomes black, then you will clean it with the gauze piece and check the back side on your back of the hand first, and then check it to the patient. And if it is not too hot or acceptable temperature, then depress the tongue and introduce the mirror with facing upward. Mirror will be in the right hand and it should be held like a pen. You should hold it like a pen and introduce inside, and then you will be able to, we have gone behind the uvula and we are able to visualize the structures. So structures which are seen at the posterior end of the nasal septum, posterior nasal cavity, eustachian tube opening with torus tuberous. Again, remember that torus tuberous is a part of the Voldier's ring. Then fossa of Rosenmuller, which is behind this torus tuberous and eustachian tube opening. Adenoids in case of children, these are normally present. And upper surface of the soft palate. These are the normal structures which are visible. So if anybody asks you question regarding any pathology, you will be able to visualize. So you have to say adenoids hypertrophy, not simple adenoids, because simple adenoids is a normal structure which is present. But as you all know, they disappear after the age of 15 years. So again, this is the diagrammatic representation, the adenoid structure, posterior end of the turbinates, posterior part of nasal septum. This is the posterior surface of soft palate. This is the eustachian tube opening and pharyngeal tonsil, torus tuberous. Not pharyngeal tonsil, the torus tuberous. So in the next picture I'll show later, the structures will be more clear. So again, this is the same how you introduce and the close-up view of the structures you will be able to find. Again, remember that indirect laryngoscopy, it is easy to visualize the structures more clearly than in posterior rhinoscopy. In a very cooperative patient or who have little widened nasopharynx, then the structures can easily be visible. Otherwise, the best way to examine the nasopharyngeal structure is the rigid nasopharyngoscopy, rigid nasoendoscopy, or the flexible nasopharyngoscopy. So this is the probable, I mean the best diagram which I am able to find out, and this is the same diagram you will be drawing when you will be asked to draw the structures visible on posterior rhinoscopy. So adenoids, posterior part of nasal septum, posterior ends of the turbinates. This is the eustachian tube opening, this is the torus tuberous, and this area behind, it is the fossa of Rosenmuller. This is posterior surface of soft palate and uvula. Okay, so these both pictures, this is the endoscopic, not the posterior rhinoscopy view, but endoscopic view of the nasopharyngeal area where you will be able to see the adenoids, posterior part of nasal septum, posterior end of turbinates, eustachian tubes, this little enlarged tubal tonsil, torus tuberous, and this part behind here is the fossa of Rosenmuller. Like this is the fossa of Rosenmuller. This is the endoscopic view through the nose. This is the eustachian tube opening, torus tuberous, and fossa of Rosenmuller. This is the nasopharyngeal vault of nasopharynx where adenoids are present. This is the nasopharyngeal wall, and this is the posterior end of the septum. So this again is just to show you the areas and the structures normally visible, but this is not the posterior rhinoscopy view. Tips for success is warm the mirror properly, but before warming, explain the procedure properly to the patient. You have to tell the patient that where you will be using a mirror to visualize the back side of the nose and nasopharyngeal area. To do that, you will heat the mirror slightly, but you will get it checked to the patient. It will not be too warm. Then you will depress the tongue and introduce it inside the mouth. The patient has to breathe normally through the mouth, and when you say to pronounce after you aha, because it will open up the nasopharynx, then the patient will do that. So proper counseling and reassurance is must. Warm the mirror properly, reassure and instruct the patient properly. Use topical anesthetic if needed. As I mentioned, if the patient is apprehensive or have excessive gag, then you can use this spray or gargles or drops. And you have to be gentle but quick. So conclusion is that posterior rhinoscopy is a valuable tool to identify the pathology in nasopharyngeal area, help to diagnose nasopharyngeal pathology, and requires patience and practice. It will not be possible to just get it properly done in first or second go. You have to practice it, especially when you are in your clerkship, in your clinical wards. You have to practice it again and again to get hold of all these procedures. So you will now see the actual procedure, how I am performing this, and thank you. Posterior rhinoscopy is being performed. The mirror is heated from the mirror side. Now it will be checked to see if it is too hot on the examiner first and then on the patient. And when it is suitable, then now we'll depress the tongue. Tongue should remain inside. Posterior rhinoscopy mirror will introduce inside facing upward behind the uvula and ask the patient to say ah to just visualize the structures behind. So this is the procedure of posterior rhinoscopy.